So I'm not sure how many people have seen Alzheimer's brains before. You can see here the tremendous atrophy. So you get a shrinkage of the brain, and therefore the spaces where the spinal fluid are actually shows, for example, the ventricles. You can see that they actually get bigger. And one point to note here is right here, you can see this is a little region within the pons that's in your brain stem. And this area is actually called the Locus Ceruleus, which basically means the area of blue. And you can see the darkness here. And this is what actually goes first in Alzheimer's. And this is the area that sends out projections of norepinephrine. So it's like the adrenaline for your brain. One of the reasons why probably when you see people with Alzheimer's, they're often a little slow. They're often looking around for answers. They're slowed down. So you lose very early on. And you can see here, if you look at the bottom here, you can actually see the loss in that blueness and that darkness of that particular region, the locus ceruleus and the pons. Then, of course, entorhinal cortex. This is area critical for memory. These are all beginning to degenerate, then ultimately much of the cerebral cortex. And if you look at the pathology under the microscope, first thing, of course, this is all related to synapse loss, and that's the most important thing that's happening in Alzheimer's disease. You are losing the connections. You have about 500 trillion synapses in your brain. So you have a remarkable supercomputer inside your brain. These are beginning to be lost as you develop Alzheimer's disease. And in association with that, you see three things that are striking within the brain. The first thing is you see this accumulation right here of, this is called amyloid, and this is largely related to a single peptide that we'll talk about and why that is important, but why it's not the only thing that's driving Alzheimer's. And when it's been talked about as the cause of Alzheimer's, there's far, far more going on than just amyloid in Alzheimer's disease. The second thing you see here, these are called neurofibrillary tangles. And what they look like is someone took a nice big neuron and shrank it down and filled it with this dark substance, which is exactly what happened. You have phospho-tau, and we'll talk more about phospho-tau in a few minutes and what you can do about it. Then the third thing here is that you see inflammation, and it's especially activation of the innate immune system, and especially the memory part of the innate immune system. And that's critical because when you have a response, normally what happens, of course, is you initially have inflammation, you have activation of your innate immune system. That's the evolutionarily older part of your immune system. And then literally it hands off to your adaptive system. So now you're coming up with your B cells and T cells. These are the ones that are more specific, that are going to now root out the pathogen and get rid of it. And this actually then turns down the innate, turns off the inflammation, clears the pathogen, and then you reset. The problem is COVID-19 and Alzheimer's actually have something in common. In both of these cases, you activate the inflammatory part, but you don't get enough activation of the innate part, of the adaptive part to clear the pathogen. So either because, for example, you're in ill health, as we know with COVID-19, so people then continue to have this activation of the innate system. And what happens? They die from cytokine storm. In Alzheimer's, the same story, but instead of cytokine storm, it's cytokine drizzle. You have this chronic activation for decades of the innate immune system, and your adaptive system is failing to clear this, either because you have had continued exposure to things, that's one common reason, or because you're in poor health overall, or many other reasons that we'll talk about in just a few minutes. So this is the problem, and we need to address this as early as possible. So as I said earlier, the key issue is, what is it? What is Alzheimer's? This has been the problem, trying to develop a drug to get rid of Alzheimer's without understanding what Alzheimer's actually is really makes no sense, but that's what's been going on for decades. There is no agreement, interestingly, among the experts on the disease. The epidemiologists show us many risks from early menopause. If you have an early, for example, if you have an early oophorectomy at the age of 40 or younger and you don't have hormone replacement, you double your risks for Alzheimer's. Even though the Alzheimer's comes many years later, you actually double the risk. Low vitamin D, herpes simplex, insulin resistance, hypertension, metabolic syndrome. These very, very different risk factors are all risk factors for Alzheimer's disease. I mentioned the pathology just a minute ago. The genetics, over 50 associated risk genes. They're now actually closing in on 100 different risk genes. The most common one is APOE4. And so it's something we should all know. We should all know our genetic risk. And interestingly, recently, a geneticist said she would not want to know her genetic risk because there's nothing you can do about it. As I'll show you today, nothing could be further from the truth. We should all know our risk, and we should all get on active treatment or prevention. Microbiology, interesting. There are many pathogens that have been associated with Alzheimer's, from things like P. gingivalis, from poor dentition, T. denticola, herpes simplex from the lip, HHV6A, which comes in through the sinuses, Lyme disease, spirochetes, other tick-borne illnesses, various fungi, candida. All of these things have been associated with Alzheimer's disease, but it's not just one, and that's been the problem. And then finally, the translation, what happened? This represents a field of greatest medical failure. Why has there been such failure? If you come in with Alzheimer's, if you come in with ALS, if you come in with frontotemporal dementia, the doctor will tell you there's nothing you can do. So let's develop a treatment. Let's look at what you'd want to do in an optimal situation. And let's look at, what do we need to look at? So people have said many different things about what this is. People have spent their whole careers working on the idea that this is just about amyloid. Let's get rid of the amyloid. And as I showed you a few minutes ago, you get rid of the amyloid, it doesn't make you better. It may slow your decline just a little bit, but it doesn't really make you better. Some people believe this is all about tau, others that it's prions, type 3 diabetes, chronic herpes simplex, on and on and on. None of these has led to an effective treatment. So what do we need to do here? So what do we have to explain? We have to explain these disparate risk factors that I mentioned before, all sorts of different things. The many risk-associated genes, the amyloid, there's clearly implicated. There's something going on with this amyloid, and yet it fails in the drug trials again and again and again. The age-associated risk, it just goes dramatically up, and especially for people who are now 65 and over. Although interestingly, when I was training, we never saw people who were in their 50s with Alzheimer's. Now it's one of the most common things we see, and even in their late 40s. So this is turning out to be very common. And actually, there was an epidemiology report about 2 years ago showing that indeed the risk and the incidence has climbed dramatically in the 40s and 50s over just the last 10 years. And then interestingly, there is a mouse that develops Alzheimer's disease that simply has in its genome an antibody to nerve growth factor. So we need to understand why that would cause that problem. And then these aggregates, and doctors will tell you, oh yeah, it's the aggregates, it's A beta, or it's tau, or it's TDP-43. These are all present, by the way, in the brains of patients with Alzheimer's. Over half of Alzheimer's patients, when you look in their brains, have these aggregated proteins, but not just amyloid, not just tau, another one called TDP-43, and another one alpha-synuclein, which is actually characteristic of Parkinson's disease. So why do you get all these aggregates? And then, of course, the remarkable failure over 400 clinical trials, and then the fact that, yes, these things do increase themselves. And so the idea of prions, a Nobel Prize was given to Professor Stanley Prusiner at UCSF from his work on prions, showing that these are proteins that beget more of themselves. So they're almost like subviral particles, little things that beget more of themselves. We need to understand why that is and what role does that play in this disease. And then the high incidence and prevalence. Why is it so common? So any accurate model must be predictive, and it must be internally consistent with all the different data, all the different papers, and most importantly, make people better. That's the key. So here's the problem. As I said earlier, simple illness, there are going to be lots of things. If you get pneumococcal pneumonia, we're probably going to do very well for you. Could be that you've got some alcohol on board, that actually increases your risk. If you've got diabetes, that increases your risk. If your B cells aren't doing well, for example, if you have multiple myeloma, and there are many others. But for physicians, the fact that the pneumococcus is so much more important than any other thing, we have gotten away with just treating you with antibiotics and ignoring all the things you've been hearing about from people like Dr. Furman and these other critical things that we need to address. Now, that simply isn't the case when you come to chronic illnesses. So if you develop Alzheimer's, one of the risk factors is insulin resistance. Another one is the pathogens I mentioned. Another one is anything that is associated with inflammation. So your NF-kappa B, and you can literally trace a molecular pathway from NF-kappa B to the production of the amyloid that we associate with Alzheimer's disease. Mercury is another risk factor. Mycotoxins, another one. Organic toxins, homocysteine, and you go right down the list. There are dozens and dozens of things. And as you can see, none of these is head and shoulders above everything else. So we can't simply write a prescription that's going to get rid of Alzheimer's just by targeting one thing. That's the fundamental problem. So we therefore need to look at what's causing this for each person and then address those things. So let's look under the hood, and I'll show you why we do what we do, which has worked better than any other approach so far, and why we've done the trial that we have. So in your brain, in your 10 to the 11th, so you've got 100 billion neurons, as I mentioned earlier, 500 trillion synapses. It's really quite remarkable. And so you've got this molecule called APP, which is amyloid precursor protein. And this is a really interesting switch. This thing is literally gauging where you stand. When things are good, you have enough hormones, nutrients, you don't have too much inflammation, you've got enough energy. This thing is cut at a single site, and it produces two peptides, one for outside the cell here, one for inside. So this is the cell membrane and the neuron here. You can see here inside, outside the cell. Things are good, and it tells you you're going to go ahead and you're going to make new connections. And by the way, this is the same sort of thing that we saw in our country when we had the pandemic in early 2020. And I thought it was interesting that the WHO, of course, has just declared the pandemic over. Of course, people are still developing COVID-19. So on the other hand, when things are bad, this same molecule is cut differently at 3 different sites. And now you've got 2 things on the outside and 2 things on the inside. And by the way, you can see here's the amyloid. This guy right here is the thing that makes up the amyloid. But there's much more to the story, as you can see, than just that. So literally, just as our country switched in its mode and said, okay, in early 2020 said, stay in, don't go into work, you're going to socially distance, you're going to shelter in place. And of course, we went into a recession. We changed the nature of what we were doing in our country. Your brain does the same thing. When it is doing well, it is making and storing connections. When it now gets exposed to insults, pathogens, severe stress, insulin resistance, reduced hormones, reduced blood flow, reduced oxygenation, reduced mitochondrial function, on and on. It basically says, okay, I have to go into a protective downsizing mode. And therefore, it flips over to producing these guys, which now go and say, okay, we're going to pull back. And for example, amyloid beta is a wonderful antimicrobial. So it kills not only bacteria, it actually kills viruses and fungi. It's quite striking. So what that means is when we look at these chronic illnesses, they are fundamentally signaling imbalances. And it really tells us Alzheimer's disease is ultimately a network insufficiency, as I'll show you. So when we get osteoporosis, what happens? We know that our osteoblasts, these little guys right here, are not doing as much work as the osteoclasts. This is this multinucleated thing here. Normally, you're putting down some bone, you're picking up some bone, you're putting it down, you're constantly remodeling it, making your bones nice and strong. But of course, as we get a little older, we have an imbalance between the blastic and the clastic part. Cancer, same idea. In this case, though, where the cytoblastic activity exceeds the cytoclastic activity, typically because you've been exposed to carcinogens, smoking, organic carcinogens, on and on. And so they actually damage the DNA. They change this balance and cells start growing, unfortunately. What we discovered in the laboratory is that Alzheimer's is no different. You have a whole set of things that are synaptoblastic, that are helping you make your brain more synapses. You can learn new things, do new things. Unfortunately, they are chronically exceeded by the synaptoclastic signals, which are various insults, and we'll talk about those. So what that means for the engineers in the group here is that your probability of getting Alzheimer's is proportional to an integral over time. So you're developing this over years. Now, this doesn't tell you what test to order. The good news is this is about the same as 4 things: things that are causing inflammation, things that are causing toxicity, things that are reducing your energetics, and things that are reducing trophic support. And the take-home message here is you can reduce Alzheimer's mainly, 90% of it plus, to 2 things. It's too much activation of the innate immune system, so immune activation, and too little energetics to cover that. So you've got this beautiful supported brain, but it is living on the edge. It's living on what you are giving it. And as you now give it less and demand more of it because you've got ongoing inflammation and toxin exposure, you are now, unfortunately, making it so that it has to do the same thing that our country did during the pandemic. So you're now cramming it into a smaller and smaller space, unfortunately. What this means is if we were going to develop one drug that would do something for Alzheimer's, it would have to look like this. It would have to do all these different things, which is a huge order for a drug. So we really need to look at protocols so that we can heal these various issues. We want to reduce the inflammation, get rid of the things that are causing it, and then we want to increase the energetic support. If we can accomplish those 2 things, we can make people so much better. And we see it again and again and again. And I'll show you the results of our clinical trial where we saw exactly that. So what I tell patients is, you got a roof with 36 holes. We got to look. A drug is a really good patch for 1 hole, but it's not going to do all the things that you need to do. It also shows that people get it for different reasons, as you can imagine. Some people because there's too little energy, some people because there's too much inflammation, some people both. So there are people who get this mostly because of infections. Some were what we call atrophic. They have reduced hormones, nutrients, and growth factors. And then some people, we call this glycotoxic, and we call it type 1.5 because it gives you both. It gives you inflammation because of your glycated proteins, but it also gives you an atrophic response because you have insulin resistance. So your brain does not respond to insulin. And when we used to grow neurons in the lab, you always had to include insulin, transferrin, and selenium. These are the so-called ITS. These are the critical factors to grow neurons in a dish. They have to have insulin. So as you lose that effect, unfortunately, the neurons don't do well. And then toxics, what we call type 3, can be inorganics, can be organics, can be biotoxins. And then vascular, this is a common contributor. And then finally, traumatic. And then if you actually look at what happens when you have head trauma, amyloid is an early response to the head trauma. So I want to spend just a couple of minutes talking about the most important and the most common gene that is associated with Alzheimer's, because there are 75 million Americans who have a single copy of APOE4, and there are about 7 million Americans who have 2 copies of APOE4. Now, if you have 0 copies, and that's 3/4 of the population, your chance of getting Alzheimer's during your life is not 0. It's about 9%, but it's not too high. If you've got a single copy, and again, 75 million Americans are in that situation, the vast majority don't know it. We should all find out and get on active prevention so we don't have a problem. And of course, everyone heard recently about Chris Hemsworth, who found out that he has 2 copies, so he's in the toughest situation. And really, of course, this is going to be on active prevention. So single copy, your risk goes up to 30% for your lifetime. 2 copies, it goes up to 70% approximately. And there are some that it's even higher depending on other genes, some that's a little lower, again, depending on other genes. So it had been clear for years and years and years. You start out with APOE4, you end up at the other end with Alzheimer's disease, but not clear how. What takes you from APOE4 to Alzheimer's? So we spent years in the laboratory looking at this. How does this actually work? And what we found was absolutely fascinating. It showed us a lot about evolution, about shortgevity versus longevity, about Alzheimer's disease, and about the God gene. This thing has so many effects. So if you go back 5 to 7 million years, you go out to the savanna and the trees 5 to 7 million years ago, what you have is you have the Simeons, and they actually don't have APOE4. They have a simian APOE, which actually has a different characteristic than APOE4. So this was actually associated with the leap from simians to hominids here. So you can see here there was a relatively small number of changes. So it's remarkable how similar simian DNA is to hominid DNA. So literally, God touched the simians, changed very few things in their DNA, and you ended up having the hominids. Very different scenario. And of course, when I've told my wife, my DNA overall is more similar to a chimp, male chimp DNA than it is to yours. She said, well, duh, of course, you like the Three Stooges, you like ESPN, so does the chimp, et cetera. So we are remarkably similar. Now, interestingly, what has changed, much of it is related to, guess what? Inflammation. So part of what allowed us to come down out of the trees, walk along the savanna, stub our feet, puncture our feet, get wounds, eat meat that was raw, that was full of microbes, fight with our food, fight with our brethren, all had to do with lots of inflammation. We live in a more pro-inflammatory, at least when we first came down out of the trees, a more pro-inflammatory state than the simians. And so we actually needed that. And interestingly, APOE4 was the primordial gene. For 96% of our evolution, it's just been APOE4. And it's just been in the last 220,000 years, APOE3 appeared, and then 80,000 years for APOE2. So here you can see the striking differences here. APOE4 looks like columns on a house, and that's because this arginine, which has a positive, that's because this arginine here, 61, which has a positive charge, interacts with glutamate 255, which has a negative charge. So it holds these together. This was called by Professor Maley, who discovered APOE. This was called domain interaction. Now you can see here what happened then 220,000 years ago. A new mutation appeared in hominids, cysteine 112, which interacts with arginine 61. So now this looks like a nutcracker instead of looking like columns. Quite different looking molecule. So as I said, we've all been APOE4 just until relatively recently, 220,000 years ago, and then 80,000 years ago, APOE2 appeared. And now the most common one is APOE3 instead of APOE4. So APOE4 is a pro-inflammatory gene. Very helpful. If you live in a third world country, you're going to live longer and do better if you're APOE4. But if you live in the US, for example, then in fact, you're going to have additional inflammation. So, okay, we know what to do about that. There's a lot you can do. If you don't do anything, on average, you have the increased risk for Alzheimer's, and you have the slightly shorter lifespan. So what we discovered is that APOE4 binds to receptors, and that had been known before. But the surprise was it actually interacts with a molecule called REL-A, which is related to inflammation. It's part of NF-kappa B. And surprise, these actually go into the nucleus. They bind to 1,700 different sites on the DNA, and they actually turn down. These are transcriptional repressors. They turn down things that are normally turning down inflammation. So they actually allow your inflammation to stay up for longer. And if you look at all the different genes that are controlled by APOE4, you couldn't tell a better story for Alzheimer's. It has to do with inflammation. It has to do with aging and SIRT1. So it actually turns down SIRT1. It has to do with neurotrophins. It has to do with disassembling microtubules and pulling back on your neurites. It's remarkable how much related this is. So I want to show you some success stories when we actually do the right thing. Good things happen. So here's a woman, 68 years old. She's actually now been on this for 7 years. She presented with paraphasic error. So she was having problems with what she was saying. She would say the wrong thing. She had some depression. She struggled with her computer work, completing a gingerbread man, confused her clock hands, and it really scared her when she forgot to pick up her granddaughters. She actually went in and got on a drug trial. She had a positive amyloid PET. So she was a diagnosis of MCI due to Alzheimer's disease was made. So she was already in that third phase out of the 4. She scored a 24 out of 30 on the MoCA, so that's significant MCI. This was actually a professor. So she had fallen a long way to get to a MoCA of 24. Her hippocampal volume was only 14th percentile. So she began on a clinical trial for a drug that removed amyloid. And each time she got the drug, she clearly got worse. And she would kind of slowly fight her way back to almost where she was. And then she'd get another injection a month later. So after 8 treatments, she left the trial and she said, this is making me worse, not better. So she then had further evaluation. She failed her visual contrast sensitivity, which suggests she has been exposed to biotoxins. Her C4A was high, shouldn't be over 2830. Her TGF-beta-1, high, shouldn't be over 2380. So she had all the markings of exposure to biotoxins. Indeed, she ended up having biotoxins. She had been exposed to mold and mycotoxins. So she began on our protocol. She included a plant-rich, mildly ketogenic diet. This is called KetoFlex 12-3, and I'll show you more about that in just a few minutes because it's an important part of the overall approach. You need to address multiple things to get people back. In other words, you're literally addressing their synaptic network to improve them so that they can actually make and use synapses again, literally so that they can learn once again. She was treated for MARCoNS. This is the multiply antibiotic resistant coag negative staph. She went on detox among other modalities. And let's see how we're doing on time here. Okay, good. All right, so her symptoms resolved. She did very, very, very well. Once again, she could speak, she could find her words, she could cook, shop, tell time, build gingerbread man, no longer forgot to pick up her granddaughters. Actually, her granddaughters said they were really impressed at how much better she'd gotten. They noticed it. Her MoCA went to a perfect 30. Her hippocampal volume went up from 14th to 28th percentile, and she's remained stable for 6 years. And now she's in her 7th year. So there we go. So here's a guy whose family history was positive, both parents, APOE. He also had a single copy of APOE4. Amyloid PET was markedly positive. FDG PET was typical for Alzheimer's disease. Hippocampal volume was reduced. Neuropsych testing showed that, again, he also had MCI. And you can see why he had it. So his hsCRP, his inflammation, quite high. It should be less than 1. We'd like to see it more like down like 0.2 to 0.5. His is up almost 10. Homocysteine, we should like to see it at 7 or below. He was at 15. His vitamin D, we'd like to see him at 50 to 80. He's at 21. His testosterone was low. His thyroid was low. And he responded metabolically, cognitively, volumetrically to the approach that we've taken. His neurologist said he's now normal. He's done very, very well. And you can see here just this dramatic. His fasting insulin improved from 32, is very high, to 8. Now, 8 is still not perfect, but it's far better than he was. His hsCRP, again, it's not perfect, but it's much better than he was. His homocysteine came down. His vitamin D came up. He was doing very, very well. And actually, his hippocampal volume, it went up dramatically. Oops, there we go. So his gray matter volume actually went up by 23%. So this is striking improvements in all these different areas. So let me talk for a minute about the precision medicine trial for Alzheimer's. So this was done with doctors Anne Hathaway, Kat Toops, and Deborah Gordon.